Hello, everyone, and many thanks for the invitation to do this presentation on bicruciate retaining total knee arthroplasty. It's meant to be a European view. I'm not sure I can cover it for the whole of Europe, but anyway, it'll be my personal experience with bicruciate retaining total knee arthroplasty, and then with some data in the end. It is relevant to this presentation that I have received research support and act as a consultant for Zimmer Biomet. So why do we want to preserve the ACL in a total knee arthroplasty? It has to do with kinematics, stability, and proprioception. So you can take it as a way to optimize your knee arthroplasty, preserving the ACL. The window for bicruciate retaining total knee arthroplasty would be here for me. I do more than 50% medial UKAs, 10 to 15% laterals, and then the remainings would be total knee arthroplasty. So the window would be somewhat narrow in between the landscape that I just described. Indications, well, they have developed into being what I will present now. I think it wasn't always as clear as this. So for me, it's a anteromedial OA, ACL intact. You have a correctable deformity, and up to this point, you would do a medial uni. But there are some cases where the lateral compartment is with too much wear for unicompartmental surgery. It is reflected here in the radiograph also, where you see severe AMOA, where you see a narrowing of the lateral joint space. You see ACL preserved when opening the knee, and also reflected on the lateral radiograph. And then you have severe bone-on-bone, but with too much wear, with too deep defect centrally on the lateral condyle in the knee. So this is the kind of knee that I'm talking about. So you have a varus knee that corrects nicely preoperatively into a neutral alignment. So unique features of BICR TKAs, the bony island standing in the middle of the knee. You see the radiograph to the left showing this, then you see intraoperative radiograph with ACL coming down in the middle, and then you see the design of the tibial base plate to accommodate this particular feature. So principles of the technique, my experience is with the Vanguard XP. So it's developed as a measured resection technique. You make cuts relating to landmarks. You do femur first. This is just to make better room on the tibia. Then you respect the joint line. This is important. And to test this, you do a test with the femoral trident place against the native tibia. It will look like this, and you see that the knee is a nice full extension, and you see unrestricted flexion, and this tells you that the joint line has been respected. Principles of the tibia: alignment is set by the extramedullary guide. Resection height is set to accommodate a minimum size 9 bearing. Slope is set to mimic a natural slope, with the aim being 7 degrees posterior slope. And then the rotation is set based on the landmarks, and I check this against tibial tuberosity. And you see the unique instrumentation here to do the sagittal cuts next to the remaining bony island. The idea is to re-establish the medial compartment, so you do your resection there first to make sure you can accommodate minimum size 9. You aim for a size 10, not to be tight, and then you get sufficient slope, and exactly to avoid tight gaps, you have to make sure to accommodate the size 10 bearing, not the 9. So when you trial for inlay thickness, do not overstuff, because in extension you may cause a situation where you pop off the bony island if you're too tight. And I think the key learning for me has been that the bicruciate retaining total knee arthroplasty should be left with natural laxity and not be any tighter than the natural knee, since the ACL will not function properly if it's left too tight. Just a few videos to show you some unique features. You see cement pressurized into the tibia bone. You see the bony island standing in the middle, and you see the tibial base plate going in. It has a pec and keel formation, so you have to push it in and then push it down. And you see me pressurizing with my fingers, and you see cement escaping on the side of the implant there. And then you have the unique features of the inlays going in. There's one for the medial, one for the lateral side. You push them in, push them back, and then you lock them with a locking bar mechanism. And then finally, test of the final knee. You see a nice extension. You see unrestricted flexion, drop and dangle is nice. You see on the 10 degree, 15 degree flex knee, you see a knee with natural laxity, which it should be. The window for bicruciate retaining TKA would be here for me, between all my unis and then my remaining TKAs. It is now positioned next to biuni, but again, in my current setup, it has a rather narrow window of a few percent of my practice. So we did this study a few years ago, published this year in Core, a 2-year study looking at bicruciate retaining versus cruciate retaining TKA, following them with RSA analysis to see the micromotion of and stability of the tibial implant. That was the primary endpoint, also looking generally for its safety and efficacy. So 25 patients in each group, comparing Vanguard XP to Vanguard CR. So we follow them up to 2 years in this study, and then we are following them onwards also. And then what you see, the primary endpoint being the tibia migration measured by RSA. You have a maximum total point motion, which is very similar for both groups. So you have a stable migration pattern for both the CR and the bi-CR tibial base plate. So of course, this relates heavily to your cementing technique, which is of key importance. Oxford knee score, both groups have median scores and excellent range. CR starting higher, ending higher, but the delta value is the same for both groups. Forgotten joint score similar, with a ending point at just around 70 for both knees, which is nice and high for total knee arthroplasty. We had one tibial island fracture in the bi-CR group and 3 arthroscopic MUAs in the bi-CR group. And this relates to a learning curve, which again is relating specifically to the fact that these knees should not be made too tight. You have to trust the natural laxity of the ligaments. So in this study comparing Vanguard XP to Vanguard CR, we found safe fixation of both tibial base plates. We found a clinical outcome which was similar in both groups, good outcome, but there is a learning curve related to the bi-CR technique, which we have now acknowledged. Many thanks for listening to this experience.